All right, so like I was saying, using the principle, any candidate who gave more than what he was required to give, mark yourself 0. If the question asked for 4, you gave 5, mark yourself 0. All right, so let's begin. Medicine 1. Describe what you see, what cranial nerve is involved, and what is the type of lesion. Mention 4 causes of this presentation. Outline your management. So you are going to tell me what you wrote. James, what was your description here?
Hello, Doc. My description was a picture of a man with loss of unilateral facial muscle movement on the right side. The right forehead is not wrinkled, and there is loss of nasolabial fold on the right side.
Okay. As an examiner, that will qualify for a full mark. Anybody with a different answer, please? Candidates only. Anybody with a different answer, please? Okay. So, this is...
Doc.
Yes.
Hello, Doc.
Yes, go ahead.
I wrote a picture showing a face of a man with left droopy eyes, with lip twitching to the left side, with a smile sign, into bracket Gauss Palsy.
You see, you have even given a diagnosis inside. I mean, that is good, but next time stick to the instruction. That is very perfect. That is very perfect. I mean, when they give a picture, they don't expect all of us to use the same sentence, do they? So that will also qualify for a full mark. But next time, please stick to the instruction. Okay, so what I was expecting, anybody with a variant answer, that is good, Joyce. Anybody with a variant answer, please. Because you see, in your description, you failed to state what would differentiate between an upper motor neuron lesion and a lower motor neuron lesion. So the answer I was expecting, but it would have still qualified for a full mark. Believe me, I'm the strictest examiner you can ever meet. So I'm going to mark it with strictness. I think that will still qualify for a full mark. So you don't have to waste your time writing a picture showing. It's just a picture. Okay? Let me be very clear with you. Say, we all know it's a picture. So if you think you would have time wasting, a man with left mouth deviation and loss of wrinkling and nasolabial fold, loss of forehead wrinkling, and nasolabial fold on the right. Please write the right in full, okay? A man with a left facial or mouth deviation and loss of forehead wrinkling and nasolabial fold on the right. Is that okay? Mention that there is loss of forehead wrinkling on the right distinguishes between the two types of lesions, isn't it? Hello?
Yes, Doc.
Please, anybody with any concerns? Give me an answer. Let's move on. Anybody?
No, Doc.
Anybody? Okay. What cranial nerve is involved and what is the type of lesion? Please do not write cranial nerve involved. Yes.
Please, Dog.
I'm listening. Could
you please not claim the answer so that we can take a picture and then later on go through it again? Thank you.
What cranial nerve is involved and what is the type of lesion? Please do not write the cranial nerve involved is, and can I write another sentence? The lesion is, this is a short answer station. Your answer should be, what did you write? Sandra.
Hello, Doc.
What
Yes,
did you
so
write?
I wrote cranial nerve 7 into bracket facial nerve.
Okay. Anybody else with a different answer? Nanama, what did you write? Yes.
Please, I wrote cranial nerve 7.
Cranial nerve 7. Patience, what did you write?
Facial nerve, cranial nerve 7.
Cranial nerve 7. Okay. So, James, how about you?
Doc, please, I wrote facial nerve into bracket CNVII.
Okay. So the answer I was expecting was the right facial nerve. Or if you wrote the right cranial nerve 7. But if you met this question in exam and you just wrote facial nerve, I'm sure they would have given it to you. But like I'm saying, I am a very strong melancholic, so I like very precise answers. It is not the cranial nerve 7 on the left, but it's the cranial nerve 7 on the right. So if you meet this question, in case you meet this question, whether in your manned station or your unmanned station, you are shown this picture and you're asked to state the cranial nerve, that is, please watch the deviation. You see, this one, it looks like the paralysis here, isn't it? And so it is the cranial nerve 7 on the right, which is paralyzed, isn't it? Do you agree?
Doc.
Yes. So you just write right facial nerve. And what is the type of lesion, please?
Doc, lower motor neuron lesion.
Did anybody write anything different? Did anybody write anything differently? Okay, so this is going to be a lower motor neuron lesion. What is the evidence here of the lower motor neuron lesion? What is the evidence? Quickly. Anybody?
Hello, Doc.
Yes, what is the evidence?
Because of the loss of the wrinkling of the right forehead.
Exactly. What else?
And also there is loss of the nasolabial fold, and there's unilateral loss of the facial muscle movement on the right side.
No, but
Doc, when did like more hypotonia and those kind?
Hey, how will you be able to assess the tone in the face? How do you define tone?
Doc, hang on, Doc, what I meant is like,
The other thing is this thing, this one. The paralysis of the superior orbicularis oculi. So the evidence here is the complete paralysis of right facial muscles. And you are talking of what? What muscle is here? What is the name of the muscle here?
Frontalis muscle.
That is what is causing the loss of the frontalis muscle. And the what? You know that this one is also part, right? The superior orbicularis oculi. Okay. If it were upper motor neuron lesion, the patient would have been able to wrinkle this and would have been able to close the eyes a bit. But the fact that all of them are paralyzed, the complete paralysis of all the facial muscles, such that the frontalis cannot even work. The superior orbicularis oculi cannot work. That is what makes it a lower motor neuron lesion, isn't it? It means that for question 3, if you are answering, then the causes should only be lower motor neuron lesion cause of what? Facial nerve palsy. So, Joyce, what did you write? 1. What did you write?
Doc, I wrote trauma.
Hey, be careful. Be careful. What did you write?
I didn't answer.
Patience, what did you write? Anama, what did you write?
Doc, I wrote Bell's palsy.
Jennifer, follow.
Please, I wrote Ramsey-Hunt syndrome.
Sandra, what did you write? James.
Yes, Doc.
What did
Brain
you write?
tumor.
Come again.
Brain tumor.
That is an upper motor neuron lesion, and I won't take that.
Okay, Doc, Lyme disease.
Farida, what did you write?
Dog.
Yes.
They mentioned all my own.
Yo. Jennifer, is there anything you wrote in addition to the 3?
Parotid gland enlargement.
So you can simply say parotid gland tumor. What else? Middle ear infections, okay? Parotitis. So you see, can I clean my board? Have you finished taking?
What of organophosphate poison?
Yes, it works. It works.
So please, how about Guillain-Barré?
It works.
What I didn't say that one.
So Guillain-Barré, poliomyelitis also works. But if you are writing, you know that Bell's palsy is the most common. Ramsey-Hunt syndrome or herpes zoster oticus, okay? Lyme disease, yes. Organophosphate poisoning, yes. Parotid gland tumor, yes. Middle ear infections, yes. GBS, yes. Middle ear infections, yes. So you are looking at causes of what? Even sometimes cerebellopontine, okay? Or let me say acoustic neuroma. What you guys as acoustic neuroma has now something that and I've explained before. It is actually schwannoma. So vestibular schwannoma, in addition to all these and then the correct answers you've mentioned, qualify. Now listen. Like I explained last time, you know that neurons are arranged, motor neurons are arranged this way, right? There is always an upper motor neuron which comes to the brain, and then that neuron will come and synapse on a lower motor neuron. That is the origin of these terms, okay? Upper motor neuron, lower motor neuron. Now, when we're discussing the anatomy, when we're discussing strokes and we're doing neuroanatomy, remember we said that the lateral part of the motor cortex is where the face is when we're discussing the motor homunculus. And we said that the neurons which come from that part, the motor cortex, constitutes the what? The upper motor neurons, and they will come and synapse on the nuclei in the pons, at the pontomedullary junction, the junction between the pons and the medulla, synapse on it, and then those neurons would come out, and then this is what will form the facial nerve. So this is the upper motor neuron of the facial nerve, and this is the lower motor neuron of the facial nerve. And so, for example, brain tumors, whenever you have a tumor compressing on this, you can have an upper motor neuron. When you have a stroke, an infarct or hemorrhagic stroke, which is compressed, the infarct has killed this thing because of ischemia, or there is hemorrhagic stroke here and it's compressing on this, or there is a cerebral abscess and it's compressing. So I'm mentioning the causes of the upper motor neuron lesions. You have a CVA, you have a brain tumor which is sitting inside the cerebrum, you have a cerebral abscess, will compress on this neuron, and that will cause an upper motor neuron lesion. So all the lesions that would what? All the conditions that will affect this neuron is what will give rise to the lower motor neuron lesion, okay? And so we are saying that the facial nerve, please, are you all following? Sandra, are you following? You were not here, so are you following? Give me a response, please.
Hello, Doc.
Are you following?
Please.
Yes.
Yes, I'm following.
Sebastian, are you following? Is he here? Sebastian, are you following? All right.
Yes, Doc.
Good. And so all the conditions which will affect this neuron is what we are talking about. Now, if you have a tumor in this region, if you remember the drawing we've been drawing, this is the cerebrum. Of course, this is the brainstem. So we have the midbrain here, the pons, the medulla, and then the spinal cord continues. And remember that we have the cerebellum here, okay? And this is the cerebrum. So that is the brainstem. Sorry, that's the midbrain. That is the pons. That is the medulla. So imagine a tumor coming from this one, this place, and it's compressing on the medulla. the upper part, in this junction where the facial nerve nucleus is, this tumor can compress on this one, and then it will cause a what? A lower motor neuron lesion. So if you say brain tumor, you have to be very specific, because we know that when we talk of brain tumors, we are talking about the astrocytomas, the epidermomas, we are talking about the glioblastoma multiforme and all that. And all of those are higher up, okay, in the cerebrum. When you say cerebellopontine tumor, this is it. Cerebellopontine tumor. So there's a tumor which is arising from the junction between the cerebellum and the pons. And then it can compress on this part, and then it will compress on the nucleus here. And that will cause what? A lower motor neuron lesion. Okay. Now, if you remember the cause of the facial nerve, I sent you a video on facial nerve examination, and then I think Bright asked me about the cause, and I just give you an overview. Now listen, let's go to the net and then stop this black man style of teaching. Let's go here. There are a lot of things on this image, but I'm just hoping that you can single. I'm coming. Give me a minute. Let me see this. No, I don't want this. It's even mixed. Let me see this. Can you appreciate this a bit? I'll explain. Can you appreciate this a bit? Please give me a response. Oh. Can you appreciate this? Give me a response.
Yes, Doc.
Yes, Doc.
So this is the pons. That is the second part of the brainstem. Now watch this. The facial nerve begins this way, and then it gets out. Okay, so remember that the upper motor neuron is come to synapse on it. We have described the complex connection between the upper motor neuron lesion and the facial nerve nucleus. If you remember this one, the facial nerve nuclei, they're about 4. This one was supplied, this is supplied. That's not what you're talking about. You forget that. Now, the facial nerve would come out through the pontomedullary junction this way. So it comes out of the pons this way. Okay. And then remember that I said in the it comes out as the motor nerve, and then its sensory root joins it. Okay. And then both of them enter the internal acoustic meatus. Then when they enter, a lot of things happen. For example, it goes through the middle ear. Okay, and then there's a branch called the petrosal nerve, which goes to feed some salivary glands. Then within it as well, it forms the geniculate ganglion. I don't want to be confusing you too much, but the point I want to make here is that if you have any lesion along this pathway, all of them would produce lower motor neuron lesion, because all of them are outside of what? This nerve. So anything from here to here would produce what? A lower motor neuron lesion. Now listen, so when I say there is a cerebellopontine tumor, this tumor is compressing on this part of the nerve. That is why it will cause a lower motor neuron lesion. Now, when the facial nerve is entering the internal acoustic meatus, okay, the 8th cranial nerve joins it. The vestibulocochlear nerve, that is the 8th cranial nerve. eighth cranial nerve, again, I repeat, is the vestibulocochlear nerve. It joins it. So if there is a tumor from the vestibulocochlear nerve, do you think it can compress on the facial nerve? Hello?
Hi, Doc.
You think a tumor from the vestibulocochlear nerve can compress on the facial nerve? Yes, because it travels with the facial nerve within the internal acoustic meatus. Please hold on. That is how come a vestibular schwannoma. So last time I explained what vestibular schwannoma was. I said that what was considered acoustic neuroma is no more the case. It's actually vestibular schwannoma. Please remember, I said that the name of the cells which produce myelin sheath in the peripheral nervous system, they are called Schwann cells. Okay. Do you remember? So when the Schwann cells undergo become cancerous, or you have a tumor in the Schwann cell, you are going to get a schwannoma. And it's actually the Schwann cell which surrounds the vestibular nerve that is responsible. Because you see, this nerve is called vestibulocochlear nerve. It's made up of two nerves, the vestibular nerve and the cochlear nerve. The vestibular nerve responsible for what? Balance and equilibrium. Cochlear nerve responsible for hearing. And so if you have the Schwann cell around the vestibular nerve becoming tumor-like, then you would have a vestibular schwannoma. And this nerve is running within the internal acoustic meatus with the facial nerve. So if you have a tumor, the tumor can grow and then compress on the facial nerve, and that will cause the problem. You understand? Please, you understand? Do you understand? Please give me a response, or else I'll move on.
Yes.
Yes.
If you follow it here, remember that we said that it passes through the middle ear from our previous picture. So it means that middle ear infections can also cause problems. Okay, so otitis media, if it becomes bad, can cause facial nerve palsy, lower motor neuron lesion. And again, we are saying that it goes through the substance of the parotid gland. That is why if you have a tumor of the parotid gland and it is compressing on the nerve, you can have a facial nerve palsy. Does that make sense, please?
Yeah,
all right, okay. Okay, good. Good. So outline your management. What did you write? Learn how to write simple but accurate answers. What did you write? Anybody? Reader, what did you write? James, what did you write?
Doc, I wrote steroid therapy and antiviral like acyclovir.
I agree. So antiviral drugs. The steroids, you don't usually give it. So before I write that, I would write facial muscle physiotherapy. How do you ensure that the patient undergoes facial muscle physiotherapy? Anybody? Joyce? How do you ensure the patient undergoes facial muscle physiotherapy?
Is it that you book it?
You don't say is it, you are a candidate. Stop saying that. Answer the question.
You book the patient at the hospital, or you assign a physiotherapist to see the patient.
What will the physiotherapist do for the facial weakness?
No, is it massage?
You're also saying,
The-
is it? Do you know that thing really annoys your examiners? He's asking you a question and you're answering with a question. I said, stop that. Answer the question.
Yes, no.
What will the physiotherapist do? What will he tell the patient to do for his facial weakness?
Doc,
You tell the patient to
massage.
try to blow balloon.
Blow balloon. Okay, what else? Chew gum.
Like chew gum.
Chew gum. Please, I'm repeating. I'm repeating. Stop. That is it. I don't know where you guys learned it from. Stop it. Even I, who am not an examiner, it's even very, very, very annoying to me. Stop it. It annoys your examiners. Stop it. If they ask you a question, go ahead and answer. Don't ask them the question. Don't answer the question with a question.
Doc, please, want to take a picture?
Can I move on?
Yes, please.
Describe this fully. What did you write? This picture can be shown you in your unmanned OSCE and in the manned OSCE diagnostic station. If you were shown this in your unmanned OSCE station, what would you have written? Or what did you write? Patients, is Sandra with you?
Doc.
Is Sandra with you?
No.
I think her network is giving her problems. All right. Yes. Anybody? What did you write?
Doc,
Uh-huh.
an image of a non-contrast head CT scan showing a hyperdense area in the left hemisphere of the brain with collapse of the left third ventricle.
Then third ventricle.
Lateral ventricle, sorry.
It's not actually collapse, but it's an intraventricular extension.
Oh, okay.
And
Okay.
you see that there is some of the blood here. Okay, so you are going to say, instead of saying a non-contrast, you can just say a plain. Okay, so
Okay.
the answer you are looking for is a plain head. If I were the candidate there, I would have written in full. Computerized tomography scan. But I don't think you'll be penalized if you write head CT scan. Showing a hyperdense lesion in the left cerebral hemisphere with intraventricular extension. What is your diagnosis? What did you write? Talk, so that we can do more things today. Talk. You don't have time. Don't let me mention your names. Candidates, talk.
Doc, left intracerebral hemorrhage.
Okay. I wouldn't left intracerebral. Who else has it? Who else? Who else?
Yeah, look.
Uh-huh.
Yeah, look. I went for subarachnoid
Hemorrhage. Okay. Who else? Who else? Acute
Hemorrhagic stroke.
left hemorrhagic stroke.
So Sandra is here now.
Okay. Acute left hemorrhagic stroke. Please, the acute should come because okay, I don't think I don't think you were here. But Joyce, if you remember, whenever you have a blood collection like this, the hyperdensity is the same as the bone. It means that it is fresh blood. And so whatever caused the hemorrhage is actually an acute event. Okay? And so it should come. You don't just have to write hemorrhagic stroke. The person who wrote hemorrhagic stroke and then the person who wrote a left acute hemorrhagic stroke, you are different. You are different. Okay? But if you have the lesion which is, closer to that of the brain parenchyma, then instead of an acute stroke, it becomes a subacute stroke. So you see, the point is that whenever you have a hyperdense lesion in the brain, it is white because of what? Calcium. Just as there is calcium in the bone, what will make it pick up so much of the waves or the rays is because of the calcium. So that is what? An acute left hemorrhagic stroke. That is the answer. Please, an acute, if you are shown this in your man station, candidate, describe this lesion or describe this x-ray. Sir, please, describe this CT scan or describe this imaging modality. Sir, please, this is a plain head CT scan showing a hyperdense lesion in the left cerebral hemisphere with intraventricular extension in the inferior horn, isn't it, of the left lateral ventricle. Okay, what's your diagnosis? Don't just say hemorrhagic stroke. Of course, it's a hemorrhagic stroke, but you can have an acute hemorrhagic stroke and then what? A subacute hemorrhagic stroke. And I'm saying that what makes it acute is the fact that the blood has a similar intensity as the skull, the bone. Okay, white, and so that's an acute, and it's left hemorrhagic stroke. Don't forget that whenever you are given an imaging modality, and then you are confused whether this is the left or the right, just view every imaging modality as the chest x-ray. And remember that always the left ventricle is here. Always this part is labeled left, isn't it? So never get confused. If you think that you are getting confused, just look at the lesion and then place the x-ray on it. You realize that the heart's left is always here. So this is a left part of the brain. However, actually, our left is actually the radiologic right. So this is the radiologic left, but that is our right. When you're looking at this picture, you're looking at it with your right eye, but that is the radiologic left. If that rule is confusing to you, anytime you are given an imaging modality, just compare. Where is it? Okay, if this were an x-ray, the heart would have been here. So this is the left. All right. Then the question is saying, question 3 says, mention 3 causes of this picture. What did you write? If you go to the diagnostic station in internal medicine, and then you are shown this, okay, very good. You think it's an acute left intracerebral hemorrhage or an acute left hemorrhagic stroke. Then you are asked, what are the causes of this? What would you say?
Doc.
Yes, go ahead.
It's poorly controlled hypertension.
Thank you. Poorly controlled.
Rupture.
Wait, poorly controlled hypertension. Very good. Very good. Poorly controlled hypertension. Go ahead. Go ahead.
Listen, Cerebral aneurysm rupture.
Okay, so a rupture of an intracerebral aneurysm. Okay, what else?
Trauma, dog. Head trauma.
I'm not accepting that.
Okay.
Go.
Subarachnoid hemorrhage.
Subarachnoid hemorrhage, eh?
Yeah.
So what else?
No.
What else?
Arteriovenous malformation.
Okay, so it will also fall here. So let me just write that. Rupture of an AV malformation. Joyce, what did I teach you? Joyce, what did I teach you? What did I teach you? Go ahead. Is she here? All right. So I thought a mnemonic smash you. S for structural anomalies. Let me stop sharing this and I'll come back. When you go to the Viva station or the picture station Unmanned OSCE and you are shown this and you ask for causes of intracerebral hemorrhage, remember smash you, although there are other causes of intracerebral hemorrhage. This is what everybody knows. Even the senior residents, the consultants, everybody's familiar with this. And I've told you that to pass this exam, it's a song. Okay? S for what? Structural anomalies. Structural anomalies. Like a ruptured Berry's aneurysm, an AV malformation, M is for what? Medication. Medication. Warfarin, heparin, etc. A for amyloid angiopathy. Amyloid angiopathy. What is an amyloid? What is amyloidosis? So an amyloid is an abnormal protein, okay? An amyloid is an abnormal protein that is produced in the body. When we say angiopathy, angio means vessel, pathy means disease. And so amyloid angiopathy is when an abnormal protein deposits within the walls of the vessel, which makes it weak. And because it makes it weak, any rush or any pressure that the heart pumps, when that blood is moving with a little force, because the amyloid has weakened the blood vessel can leak its content, which is blood, into the tissue space, in which case, if the amyloid angiopathy has affected the cerebral vessels, you would have a bleed into the brain. Do you understand? Do you understand?
Yes, Doc.
Silent majority, do you understand? Give me a response.
Yes.
If you don't respond and I move on, trust me, if you ask me a question, I won't mind you.
Doc, please, is Berry's aneurysm the same as circular aneurysm?
You wouldn't say they are the same, but circular aneurysm may be a type of Berry's aneurysm.
Oh, okay. Thank you very much.
S for systemic conditions. Systemic conditions like chronic liver disease. Because the liver is responsible for producing the clotting factors. And so if it is diseased, we can't produce clotting factors. So the body will be in a state of what? Anticoagulation. And that can result in a bleed in the brain. Again, chronic liver disease may be associated with thrombocytopenia, as I explained last time. And that can also contribute to the bleeding into the brain. And then the H is for the hypertension. U is undetermined or idiopathic. However, getting this smash U in your head, when you are asked, please do not start with structural anomalies. The most common cause is a poorly controlled hypertension. After you've mentioned the hypertension, that is when you would mention the rupture of Barrett's aneurysms, circular aneurysms, AV malformation, medications, overdose of or inappropriate intake of warfarin, medications like warfarin, heparin. Then you have amyloid angiopathy. You have systemic conditions like chronic liver disease. Is that okay? All right. So please remember smash U. Thank you. So we've described this. We've said something about this. Then we are saying that here you write short. You can just write poorly controlled hypertension. Then you move on. You come to a ruptured Barrett's, or you can say ruptured intracerebral aneurysm. Amyloid angiopathy. Is that okay? Can I clean my board? Can I clean my board, please?
Yes.
State 4 clinical signs that can be elicited in this patient. What did you write? James, what did you write? Say it, let's go.
Doc, headache.
It means you failed to answer the question. Understand the question.
Clinical signs.
You failed to understand the question. The question is asking for clinical signs.
Doc, right-sided weakness.
Okay, so right hemiplegia or paresis. What else? What else?
Doc,
Go ahead.
right hemisensory loss.
Okay. I wouldn't fault that. Go ahead.
Doc, select speech.
The can sign on. They say, wow.
Aphasia.
I'll pass that. Move on. We are asking for signs of upper motor neuron lesion here. You've given me right hemiplegia, right hemisensory loss. What else? What else? Joyce, what
Hyperreflexia.
else? Go ahead. What did you say?
Hyperreflexia.
I am teaching you how to answer these questions. So, the unmanned OSCE. Oh. When it comes to the unmanned OSCE, trust me, you get something to say. Hyperreflexia on the right.
Okay.
What else?
Right-sided hypertonia.
Yes. Hypertonia on the right. If you're able to list this four, please hold it. Don't do a lichon. Hold it and move on. Don't give 5. You score 0. I'm warning you. It's not my rule. But assuming you want to learn more, what else would you add? Yes. What else?
Increased power.
Increased power. Hey.
On the muscles on the right.
Increased power. So also right hemiplegia. Now right hemiplegia now also increased power. What does plegia mean? The right hemiplegia is telling us that there will be loss of power.
Yeah, it's true.
Yes. Sandra, what else? What else?
Clonus.
Yes, there will be clonus on the right side. Sandra, what else? Sandra, what else?
Look, she's decked out. She's washing her hand.
She's washing her hand. Patience, yes, go ahead. Joyce. Anama. Jennifer.
Absent particulation.
Absent particulation. The absence of a sign is not a sign of. Koulibaly. Koulibaly, yes. Okay. So there'll be a positive Babinski, okay? Positive Babinski on the right. So this question was testing your knowledge of what stroke and the signs you would elicit, okay? And the signs, because it has affected the brain, is most likely going to be an upper motor neuron lesion, okay? So the upper motor neuron lesions, you are going to have one, everything is high, okay? So you're going to have hypertonia as against hypotonia in lower motor neuron. You are going to get hyperreflexia as against hyporeflexia or areflexia in the lower motor neuron lesion. You are going to get, of course, there will be absence of fasciculation, but we are asking for signs, positives. We are not interested in negatives. Fasciculations. Of course, there will be weakness, okay? The weakness is common to both upper motor neuron and lower motor neuron, just that in upper motor neuron, it is spastic weakness. Then there will be what? Clonus. And then there will be positive Babinski. Please, is that okay? Is that okay, please? All right. Can I clean the board?
Yes, Doc.
What 2 medications will you prescribe for this patient? Jennifer. Anama.
Nimodipine.
Nimodipine. Is that the first thing you write? What is nimodipine used for? What is nimodipine used for? Nimodipine, although it is a calcium channel blocker, is not used as an antihypertensive. It is used in subarachnoid hemorrhage to prevent vasospasms, isn't it? Isn't it? And it's Munyano.
Yes,
James, what did you write?
Doc, monitor.
What else would you give this patient?
Antihypertensive.
Good. Anything else anybody wants to give this patient? Please, is there anybody who sincerely wrote aspirin? Who wrote aspirin? Anybody? Now, take note that another marking psychology is that if your answer is harmful to the patient, if your answer is likely to kill the patient, score 0 for that question, no matter how correct the others are. For example, if a patient or a candidate wrote aspirin, antihypertensives, you will score 0 for the entire question because aspirin is dangerous to the patient. It is an antiplatelet, and so it is going to worsen the bleed, isn't it? Intimate mo send mo mark. Now what try? What to was actual? What is here? And so if your answer is harmful to the patient, no matter how correct the other answers are, you score a 0 for question 5. Do you understand?
Yes, Doc.
A patient presented with right upper quadrant pain and a previous history of flu-like symptoms. A week ago, and she had been in contact with someone with similar symptoms. Okay, what is the most likely diagnosis? This one was University of Ghana Medical School, final part 1, class of 2021. Their question.
So, viral hepatitis.
He's saying viral hepatitis. Who wrote anything differently? Please, who wrote anything differently? Start saying your answer so that I know how to correct you. You want me to just write the answers without explaining? I can do that too. Okay. Give 3 differential diagnoses. James.
Doc, autoimmune hepatitis.
Give another one. That's not the first thing you come again.
Drug-induced hepatitis.
Go ahead. What else?
Alcoholic liver disease.
Go ahead. What else? So, because of having had contact with somebody, yellow fever. Okay, yellow fever should also come first.
What?
Yellow fever should come first. Then I would entertain the rest. Autoimmune hepatitis, and then drug-induced hepatitis. Give 4 investigations you request for in this patient.
Doc, liver function test.
What else?
Listen. Abdominal ultrasound.
Okay, what else? What else?
Doc, can you do listen?
You don't ask me that. I've warned you.
Sorry.
Answer the question.
Full blood count.
What else?
Doc, urinalysis.
Okay. What else?
INR.
Hep B surface antigen, INR, Hep C antibody, right? You are looking for the cause, isn't it?
Yes, sir.
Yes, and maybe the urine RE, that is fine. Arrange your answers so if I were the candidate, because you see, we answer, we are looking for the cause, okay? So if he's jaundice, once you find out the liver, is it fine? Then I'll follow it up with what? Hep B, Hep C. You may have to do even Hep A antibodies, okay? INR, then the abdominal scan, FBC, urine RE, among the rest. Can I move on?
Yes, Doc.
How will you manage her? How will you manage this woman, please? So, because it is likely to be acute, you don't give any antivirals typically, okay? And so you manage her conservatively. Reassurance, adequate hydration, serial monitoring of the INR to monitor for a possible encephalopathy or fulminant hepatitis. Okay, is that okay? And you can add some liver fortifiers like tab-livolin. Mention 2 sequelae that may result. Yes, what may result?
Chronic liver disease.
Okay, so cirrhosis may result. What else? You can have extrahepatic manifestations of, especially when it is Hep B. Okay, so they can have arthritis. They can have urticaria. All these are Hep B related. They can have what else can they have? Nephrotic syndrome. Or they can have liver failure, acute liver failure, okay? Acute liver failure would be number 1, cirrhosis, arthritis, urticaria, nephrotic syndrome, etc. Can I move on? Can I move on, please? Can I move on?
Yes, please, Doc.
Describe what you see. James, what did you write? James, what did you write?
A picture showing a unilateral, a picture showing the swelling of the right leg with mild erythematous change at the ankle.
I mean, that's excellent. Not at the ankle, but if you compare, it's actually the entire leg. You see, this is shinier than this. That is excellent description. So,
Doc,
yes,
let me read mine.
read.
A picture showing an enlargement and swelling of the right leg and foot.
Okay, that also qualifies, but you didn't bring the erythematous change. You can see that there's an obvious reddening here. Okay, there's an obvious reddening there. So, a picture showing right leg and foot swelling with erythematous changes. Give 4 differential diagnoses of this picture. Patience, what did you write? Voice out your answers. That is how you would write a thing correctly in exam. Where's the answer?
Cellulitis.
That is not correct. What is the correct answer?
Right-sided cellulitis.
Cellulitis of the right leg.
Yeah, cellulitis.
Go ahead. What else?
Fracture of the right
Ruptured.
Hey, from cellulitis, what is the next song? What's the next lyric?
Ruptured Baker's cyst.
Stop saying the ruptured Baker's cyst. Enjoy a second. What is it?
Deep venous thrombosis of the right leg.
Right leg, deep venous thrombosis. Write it in full. What else?
Then fracture of the right leg.
So here, after these two, you can say anything you like. Right leg fracture. What else?
Ruptured Baker's cyst of the right leg.
Right ruptured Baker's cyst. Take note of my answer, so don't think I'm being too petty. Don't be getting minus 0.5, minus 0.5 for nothing. Just writing right won't harm you. Yo. What else?
Post snake bite of the right leg.
All right. Mention 4 investigations you request for.
So,
Yes, go ahead.
wound swab for culture and sensitivity.
What is the wound?
In case, okay.
Yes.
Okay, Doc, Doppler ultrasound.
Okay.
The right leg.
Which Doppler? You have 2 types of Dopplers. Which Dopplers? Which Doppler?
That one is something like duplex.
Duplex. The venous Doppler, okay.
Venous, okay.
Venous Doppler scan of the right
Oh.
leg. What else?
Full blood count.
I agree. What else?
Blood culture sensitivity.
X-ray of the leg.
Culture sensitivity.
Blood culture and sensitivity, I agree. What else? X-ray. Someone said X-ray. I agree. Of the right leg. There's also D-dimer, isn't it?
Yeah.
All right. This one, I modified it during the exam. I said, outline your management of one of the differential diagnoses you've taken. Can I clean the board? Can I clean the board?
Yes, sir. And not please for the differentials, could you also add the elephantiasis?
What?
Oh, so that, I mean, lymphedema.
Edema. Yes, you may add that one. But looking at the picture, you know, lymphedema would give you some skin changes as well.
Okay.
So I wouldn't add that. So your answers, if you are asked for 2, the first to be cellulitis, DVT. If you ask for 3, cellulitis, those are the common ones. That's why I'm saying you should mention that first. If you don't know, you go and mention Baker's cyst. So, unilateral leg swelling, cellulitis, DVT first, cellulitis second, or cellulitis first, DVT second, you are safe. Then you can mix the rest up. All right. Of course, lymphedema is also a differential for unilateral leg swelling. Outline your management. Oh, can I clean the board? Hey,
Yes, please. You can.
Outline your management for one of the conditions. Which one would you choose?
Cellulitis.
So what will you do?
Cellulitis.
What will you do?
Admit leg elevation.
Limb elevation. You won't always admit every case to cellulitis. So. Limb elevation.
And then antibiotics cover. Or you take blood samples for necessary investigation.
You've already given an investigation, so just move on. Appropriate antibiotics. What else?
Antibiotics.
Yeah. So example, you can give example like amoxiclav, and antipyretics and analgesia like what? Paracetamol, isn't it? Assuming you chose DVT, what would you write?
DVT, you want to do a double platelet therapy.
Double platelet therapy.
Aspirin and chloroquine.
Hey, are you sure? Are you sure? How do you manage DVT?
Oh.
How do you manage DVT? Come again.
You admit.
Okay, this time I'll accept your admission. What else? Anticoagulation. Okay. Anticoagulation. Anticoagulation with either with warfarin and then heparin. On days 1 to day 3, and continue warfarin if INR is normal. And then you just write what? Serial INR monitoring on what? Warfarin, right? And if you don't want to go through all this problem, anticoagulation with a directly acting oral anticoagulants. You can give an example. Rivaroxaban admits anticoagulation and of course limb elevation. Is that okay?
But could you also consider the conservative distance like the tape stockings and other things?
Not really. Test stockings, not really. The thing has already happened. Anticoagulate. Remember that these ones, they know that. Come again.
No, I'll refinish this one because I wanted to ask, like, what's the difference between the Bell's palsy and facial nerve palsy? It's been
facial nerve palsy can be caused by Bell's palsy. There are a lot of causes for facial nerve palsy, including stroke. So facial nerve palsy, Bell's palsy, facial nerve palsy can be caused by Bell's palsy. So Bell's palsy is a type of facial nerve palsy. But I have facial nerve palsy that is caused by poliomyelitis. It doesn't mean that poliomyelitis is Bell's palsy. So Bell's palsy is just an example of a cause of facial nerve palsy. Like I said, we have various causes of facial nerve palsy, even including stroke. Okay, so Bell's palsy is not equal to facial nerve palsy, but Bell's palsy is the most common cause of lower motor neuron facial nerve palsy. Is that okay? Is that okay, please?